Hey, DNA. I'm Kate Wilson, the host of All Access DNA. Today we are talking about hypermobility Ehlers-Danlos Syndrome, or hEDS, with Dr. Taylor Kerrins, who is both a patient and a physician. He was diagnosed with hEDS in high school and is now working in both clinical care and research related to EDS. We talk about how hEDS is diagnosed and why there really isn't a genetic test at this point that can diagnose hEDS. Taylor shares his personal story as well as resources he has found helpful. And in a side note, we both learned that we went to the same high school. So let's get started. Hi, Taylor. Welcome to the show.
Hi, happy to be here.
Well, thank you for having us on and making some time, in your busy schedule with seeing patients. But I wanted to talk to you about an area and a condition that I don't know as much about, but you have both professional and personal experience, which is EDS or Ehlers-Danlos syndrome. So maybe we start there. What is EDS and what is hypermobility EDS?
Yeah, just a great question because EDS is kind of a broad term to catch a few different conditions. So technically, there are 13 conditions that fall under the name of, Ehlers-Danlos syndrome. And, there's various types. The biggest three are classical, then vascular, and the most common is hypermobile Ehlers-Danlos syndrome, or EDS. And so that's the most common one. Most of the time when you hear the term EDS, that's generally what people are talking about. And if they preface it with something, they're talking about one of the other types typically.
Gotcha. And so what happens in EDS?
So it, as a whole, falls under the umbrella of a connective tissue disease. So the connective tissue, truthfully, is a part of the body that we don't understand very well at this point in time. So it's kind of all the in-between space. So it's kind of like the area between the skin, the muscles, kind of like within bone, but it isn't those tissues necessarily. It can also help hold things in place and provide stability to structures as well as, other functions. For EDS, a lot of it revolves around the protein collagen, which is actually the most abundant protein in the human body. Makes up about 30%, of our protein. And again, there's a lot of different types of collagen. So depending on which type it is, that deals with what kind of part of the body you're dealing with. So like, for example, type 4 collagen, you might think of kidneys. Or like type 1 collagen, you might think of bones. So kind of those types of connections. Then when you have hypermobile Ehlers-Danlos, as of right now, we don't have a known genetic cause for it, unfortunately.
And with hypermobile, that's the one that people think about when they're thinking about flexibility sometimes. Like I've seen people doing different, I don't know, thumb signs or double jointed or things like that. Is that something? Doesn't
Yep.
necessarily mean that you have EDS, but that's one of the things I guess people think about.
Yeah, that's a big part of it. And it's actually kind of a requirement to
Okay.
have hypermobility to be diagnosed with hypermobile EDS, at least as of today. And so on that end, there's one scale in particular, the Beighton criteria, that we use to evaluate hypermobility today. And it looks at 9 different things. So it looks at your pinkies. So how far back can it go? They generally say it has to be at least 90 degrees. Part of it for me personally isn't just how far back it goes, also just the feel of it. Because you can have people without the condition who they can just crank their finger back anyway, but they're just pushing kind of past what the joint would like, but it allows it. Because I've had patients who could maybe get it to here, and then you can push it back, but you get resistance that entire way.
Right.
Like the joint doesn't want to do it. Whereas like, for patients with EDS or hypermobile EDS, you can get to this point and you're not feeling any pushback. So that's
And
kind of the
for
other aspect.
our audio listeners, I will say Taylor. So Taylor's pushing his pinky backwards towards his hand, and so kind of a 90 degree, but then going back further. So since you have hypermobility EDS, I think it's important too, like you said, it's the feeling. So it's sort of feeling it as if you're the doctor testing somebody for it, but then kind of what do you feel as somebody who has hypermobility EDS?
Yeah, and it's really interesting. One of the biggest things you feel truthfully is pain, actually, which
Mm,
goes along with the diagnostic criteria that we have today. And, as far as to go back to the joints, I mean, the joint can hurt, the muscles, tendons, ligaments, all that stuff that also supports your joint can hurt as well. And then the joints, they can feel very unstable, especially depending on, who you are, how active you are, and other factors that play a role into it. You can feel very unstable. Sure. Let's say your knees, bugging you that day. And like, you go to take a step and you're like, I don't know how this step's going to work out. Like, this might
mhm.
not go well for me.
Right,
You
like something
know,
might slip out of joint or okay.
joint dislocations definitely are, prevalent among
Mhm.
people with hypermobile EDS. Shoulders can be bad. It can happen really anywhere. I mean, I remember laying in my bed one night in high school and my toe dislocated just because of gravity.
Oh
Like
my
there's
gosh.
nothing happened. I'm just laying in bed. I was reading a book. So I'm laying
Uh,
on my stomach, my feet are hanging off the edge, and then just pain as my toe dislocates. It takes me
um,
a few minutes
th
to kind of like, all right, I got to take care of this. And finally get down there. You can see it's just not in the joint anymore. Grabbed it and, just pulled it out, and then thankfully kind of went back in and
uh,
like, okay, great.
well, so that was my next question is how were you diagnosed with hypermobility EDS? Because you were talking about there's kind of a range of symptoms or things that people can see, and there's not necessarily a very specific diagnostic genetic test for it. So how did they find it for you?
So, and I will say what happened with me is a little bit different than today because the diagnostic criteria changed in 2017.
Okay.
But for me, when I was in high school, I was having a lot of pain issues, the hypermobility issues as well, which people will frequently call themselves like double jointed. And that's kind of where I was. They didn't know what was going on. I got passed around from three different specialists. It's like a rheumatologist, a neurologist, and truthfully, I can't remember who the third specialty was anymore. But they all just kind of kept bouncing me back and forth in like a triangle between the three of them. And that went on for about
Right.
5 years. Everyone just gave up. They were like, we have no clue, but
Mhm.
let's get you in to see a pain specialist. So at least we could try to help on that aspect. And the pain management doctor, he was like, you know what? You remind me of a patient that I have with hypermobile EDS. I want you to go see genetics. So then I went to see genetics. And at the time, the criteria was probably too non-specific and too
Mm.
loose
Mhm.
because it was just that Biden criteria. So that 9-point scale, which looks at your pinkies, your thumbs, knees, elbows, and then if you're able to put your palms on the floor without bending your knees. So you get 1 point like for each pinky, one for each thumb, one for each elbow, and one for each knee. So that's where you
Mhm.
get the 9 from.
Okay.
And that was it. And if you just met a certain criteria or a certain number on it, which is age dependent and somewhat sex dependent, then you got the diagnosis.
Mhm. Mhm.
It has since become a little bit more focused and there's more criteria for it. So the 2017 criteria came out that has three different parts to it. And you kind of have to fill all three parts. And the
Okay.
first part is the Biden score still, though, where you have to
Okay.
have a set number anywhere from 4 to 6 or higher. And that just depends on how old you are and sex.
And then the other 2 pieces, are they tests as well with, like, what you can move in your body, or what do they kind of assess for?
The other two pieces look at other physical features sometimes
Mm,
and then also some historical features as well. So, like, one of them is do you have pain? And you
mhm,
have to have like chronic pain, for at least like 3 months, kind of related to it as well. Then some of it is like if you have had an ultrasound of your heart or an echocardiogram done and it showed like a
mhm,
valvular abnormality. In particular, the one that's been most commonly described with it is something called mitral valve prolapse, where
mm,
that valve just
mhm,
kind of comes back down a little bit farther than you might expect. But then it also looks for other just kind of general connective tissue signs. There's like bumps that form on the inside of the heel.
Mm,
And, they're not a problem or anything like that, but they're called
right.
pisogenic papules, for example. So when you stand up,
Hmm.
you can just see them kind of poking out.
Okay.
And it just looks for other sometimes little things like that, you know,
Yeah. So just some
and
things that are kind of like red flags or sort of saying, "Hey, this could go along with it." But it's also, like you said, not necessarily super specific. So just because you might have this feature doesn't mean you definitely have this diagnosis. It's kind of like a constellation pulling in all the different features together.
correct. So like on that second part of the criteria, it's got actually three parts within it. So like feature A, B, and C are what they're called. And feature A has a list of like 13 things, and you have to have at least five of those. And then like one of those is, do you have a family history of it? And then the last one is kind of the pain related issues. And you have to
Mm-hmm.
have two of those three at least.
Mhm. And did anything change or what changed in terms of having a formal diagnosis at this point? So the pain management doctor, recommended you go to see genetics. They say, "Okay, you're meeting this criteria. We're gonna say, yes, you have hypermobility EDS." What did that change in your day-to-day?
For the 17 or 18-year-old me, who was very stubborn, not much, because I just wasn't interested, truthfully. I consider
Mhm.
myself very much so on the mild end of this
Okay.
condition. It is a huge spectrum. Because one of the things that also goes along with it, and we're kind of picking up more, there's other conditions and other what we call like comorbidities that go along with this that we're not actually, they still aren't on any diagnostic criteria for hypermobile EDS, even though we see them in a large percentage of patients. So, for example, something called postural orthostatic tachycardia syndrome, or just, or in my case, I don't say I have POTS.
Mhm.
I definitely have orthostatic hypotension. There's a little bit of a distinction between the two, but
Okay.
like, so for me, I have to drink about a gallon and a half of water a day. Otherwise I start passing out.
Oh, wow. Okay.
And it kind of falls under an umbrella of dysautonomia. So like the autonomic nervous system just doesn't quite work right. And so like you stand up, your blood pressure drops and then it's
Mhm.
just not getting the blood up to your brain.
Do they
And
think that's
that can
because
cause you to
of
pass out.
it? Yeah, is that because it impacts, like you said, the connective tissue, so there's something that's in there that's helping your nervous system?
Not necessarily the nervous system part. The best thought that we have right now is actually it's more of how good your body is at returning blood to the heart. And so like blood can pool in your legs. So like just the
Mhm.
venous, like the blood can kind of pool in the veins in your legs. And the thought is that we're just not able to kind of get that blood up your legs as easily and as fast as you want it to. And then
Right.
you're just not pumping the blood as much. So then your blood pressure is low and you can pass out.
Feel faint, pass out. Gotcha. One of the things that you kind of mentioned is about like a genetic test. You also mentioned like one of the questions sometimes I ask is about family history. So at this point, it's believed that hypermobility EDS is related to genetics and it may run in families. Is there any thought that it might be caused by something outside of genetics, or at this point the belief is it's due to some type of genetic change?
The thought is it is due to something genetic. It might be a very complex genetic picture, but it follows a very consistent genetic inheritance pattern, which is what we call autosomal dominant.
Mm-hmm.
So, pretty much, if you have the condition, you have a 50-50 chance of passing it on to your kids.
Okay.
So we see that very easily in families. It's played out
Mm-hmm.
that way, which pretty much says there's a genetic component.
Mm-hmm.
Now, if it was a very easy, like single gene change, you would kind of think we would have found it already.
Right. That was my next question is, but there's also not really one that we know, right? Because there's not really a great way to test for it in terms of a genetic test.
Correct. And part of that might truthfully be we've been looking at it in the wrong way because historically it's been thought of as a primary connective tissue disease, just like the other types of Ehlers-Danlos. Some of the more recent stuff that's come out suggests it's might not be a primary connective tissue disease. It very well could be a primary immune system disorder that affects the connective tissue disease. So you get a secondary connective tissue disease, which is why you can see some features that overlap with the other types of
Ah,
Ehlers-Danlos. But some of the comorbidities that go along with it, such as POTS or mast cell activation syndrome, you don't really see in the other types of Ehlers-Danlos. You don't really see
right.
those in other connective tissue disorders. So it suggests that there's something else besides a connective tissue or primary connective tissue disorder going on.
Right. And is that where like some of the, I guess, research, ongoing kind of clinical discussion is trying to figure out what else is involved and what are some of the pathways that are involved?
Yeah, and that's kind of the big part right now. Like I remember, a mentor of mine back when I was actually in med school still and was rotating through his genetic clinic at the time. He was saying that part of the issue with hypermobile EDS isn't necessarily how to diagnose hypermobile EDS or who has it. It's saying who doesn't have it.
Mm,
Because until you can really delineate that, you get a muddy picture that makes testing and figuring out what's going on harder to do. So, like another diagnosis we have is something called just generalized joint hypermobility, which is just you're more flexible, you're more hypermobile than we consider normal, or at least more so than average.
mhm.
But it doesn't cause any other issues really. You don't have pain, you don't have other symptoms from it. And those are the patients, like if they score, 5, 6, or, however high on the bite and don't fill any of the other criteria, then they fall into that category, which
Mm.
very well could just be a spectrum of the same condition, just more mild.
Right. But it's hard to know without having identified, I would say, like a specific gene or multiple genes potentially that we could look at. Because, like you said, it could be we're casting a wide net and we're getting some things that overlap and look similar, but they might have different causes, but we just don't know at this time.
Potentially that, or just even the change is like, let's say it is one gene. Could it be that a certain type of genetic change causes a more severe disease, or a different type of genetic change causes something mild? Maybe. I mean, I wouldn't be shocked if there are multiple genes that are involved in it. We just have to see.
Well, so given that there is this like variety and still some of these questions being asked, I will say I've been seeing a lot in my social media feeds. Full disclosure, I get a lot of genetic testing stuff in my social media feeds, given what I do. But lately, I will say, like over the past few months, I'm getting hit with all these things about testing for hypermobility EDS, and people, like I said, doing some of the thumbs or moving the pinky back. Like, if you could do this, you should consider this test. Now, of course, it's a lab that's trying to sell their product, but why does it seem like there's more and more things popping up right now in terms of encouraging people to test for hypermobility EDS if there's not really a great way to test for it genetically?
Which is a great question. And I think, so one thing that I've seen as well from like one of the, what we call like direct to consumer websites in
Mhm.
genetic testing. I remember my cousin sent me one that right on the top of this web page is, we can test for hypermobile EDS. And then it talked about a certain gene, OK15 or kallikrein 15. And the reason for that is there was a study done, actually here at MUSC, or the Medical University of South Carolina, that looked at kind of families here, and they found two families that both had the same change in that gene. And it segregated kind of perfectly within those families, that those who had that genetic change had the syndrome, those who
Mhm.
didn't have it. And then they made a mouse model off of it as well. So they made a mouse that had that equivalent genetic change. And then you saw features similar to hypermobile EDS. The caveat of that, though, it isn't a straightforward answer. That genetic change does not mean you have hypermobile EDS. If anything, I think we view it more as a risk allele, which just
Mm.
means that if you have that change, you could be at a higher risk for developing hypermobile EDS, but it doesn't guarantee that you're going.
Right, right. So people that may have done the test and find it, they still probably should get some type of clinical evaluation or talk to their doctor about it because it's not really telling the whole story.
I would say if you're symptomatic, then you should just, kind of get worked up. You should talk to, your primary care physician or whoever. Truthfully, especially if you're an adult, can be very difficult in the US right now to be
Hmm.
evaluated by a geneticist for this condition. A lot of adult clinics are, for numerous reasons, unfortunately saying no to those referrals. Not saying I agree or disagree with that. I understand, but that is unfortunately the case.
So it just may be one where it's challenging right now to potentially get in to see somebody who is a geneticist if you're concerned about hypermobility EDS. There just may not be enough clinics or physicians to see that indication.
Yeah. Yeah, that's kind of the big issue, but something that you can do if you're concerned you have it. Something that you could do is just print off the 2017 diagnostic criteria. It's easy to
Hmm.
find on the internet. You can just Google 2017 hEDS diagnostic criteria, and pretty sure it's the first thing that pops up, and print it off. And you can take it truthfully, to a primary care physician, even. And
Hmm.
you can just go down this checklist. Now, the flip side of that is kind of the experience of knowing what to look for. Like, truthfully, I did during my residency, I worked a lot in like a family medicine clinic. If it was not for my personal knowledge of hypermobile EDS, I would have no idea what those pisogenic papules are. I would
Yeah.
have to look that up. But, so it might be kind of also giving your primary care physician a little bit like grace and
Yeah.
some room to figure it out too. Because while it is actually very common, especially for something that is considered a genetic disease, it's hard to know what exactly you're looking for, I feel like, for a lot of physicians. And truthfully, even for me, I feel like I'm still learning about it because we are still learning about it. Like, there's still so much more to figure out.
Yeah, yeah. I mean, it sounds like it's one of those things where, again, we're still. Some people maybe think, oh, we sequenced the genome, we know all we need to know, and that's really not the case. We're still learning a lot about a lot of different things in terms of like genetic conditions, and like
Yeah.
you said, that doesn't even go into things like risk alleles or when we have 20 different genes fitting this pattern. What does that mean? Beyond
Yeah.
just like one gene with one mutation. For somebody that's in the pediatric setting, so like a kiddo who maybe is having experience similar to what you have, or a parent is suspicious, I guess, they can talk to their pediatrician. What would be the benefit or what would be helpful in terms of trying to see if they can get this clinical diagnosis of hypermobility EDS? Like, how would that potentially change their management or maybe some things that they would need to do?
Yeah. And it definitely can actually change management. I feel like more so now than it used to, even. So, as far as for the hypermobility side of things goes, and this is the part that most people with hypermobile EDS, myself included, don't necessarily like. It's physical activity because
Okay.
it can't hurt and you have to be very careful about it. And that's where, if you have the diagnosis, finding a physical therapist who is familiar with it can make a big difference because a lot of it is learning movements and things that work and do not work. Like, I remember working with a physical therapist back when I was in medical school. They wanted me to do a certain exercise called the bicycle laying on my back. And my hip was dislocated. Like, it was
Oh gosh.
insanely painful. It
Hmm.
didn't, thankfully, but it it was close. And
Yeah.
so I learned I'm not doing that exercise. But that one is one I have never touched since then. I think
Yeah.
they had me do it like twice, and that second one, the first one wasn't great, but I was like, I'll try again. And the second time, I was like, nope, I'm done, not doing that. So that's one way that can be helpful because so right now, the kind of the general idea behind it is you need exercise, but you can't exercise like too much because you could hurt yourself, which
Hmm.
isn't necessarily the correct way to phrase that, I think,
Right.
because I think actually strength training can make a massive difference. And I think muscle mass also makes a massive difference for these patients. And that's why, so like, when you kind of look at some of the older papers with this. So, since it's a dominantly inherited condition, you would expect half the patients or so to be males, the other half to be females. Well, you don't really see that in practice,
Hmm.
though. Like, some of the older papers stated it was like 84, 86% of patients diagnosed were females. And so, why do you see that discrepancy? We're not 100% sure. There's multiple things that can probably go into that. I personally think one factor to it, and I think a lot of people would agree, is muscle mass can play a role where, males just naturally have a little bit, they have more muscle mass, which can help provide some more stability to the joints. And so you might not see a lot of the hypermobile related issues quite as frequently. And so you're just not, picking them up as much necessarily. And like I did a mini experiment on myself my last year in residency. No way is this a scientifically proven thing. I was just curious where I said, you know what, I can do this. I have the time for this right now. So I'm going to strength train with the goal of putting on as much muscle as I can. And I put on like 10 to 14 pounds of muscle, like 4 months or so. Put on a little bit
Mhm.
of fat with that too, but it was all right. And I went from being in pain almost 24/7. Like I had been in pain 24/7 for years, basically, to having about 30 minutes of pain a week after that. And I felt amazing. Like my energy
Yeah.
level shot through the roof. I like was not tired, and I was able to do the stuff, like everything I wanted to without like my joints felt sturdier. They felt more stable. And then so I did that for 9 months and had very little issue. Like even
Mhm.
the, passing out problem, I started drinking less water because I just didn't need to do it as much. I thought is, again, you kind of increase the muscles in your legs and it can get the blood up to your heart faster and easier. Yeah, I'm on the mild side of things. Like there are some people that are going to be on the severe side that this might not be as feasible for them.
Right.
So that's where you kind of have to, tailor the treatment and the exercise to the patient. I mean, I had actually back in med school, a girl that uh, a friend introduced me to. She was talking about how she was having a hard time writing now, and she was an undergrad student. And I gave her some very easy, just hand exercises she could do in order to do that, 3 times a day, 10 times, 10 reps each time. And, I was like, talk to me in 2 weeks. Let me know how you're doing. 2 weeks later, she's like, yeah, not having any issues writing anymore.
Mm.
So I think that can play a big role. And it doesn't have to be the like, all right, I need to go run 2 miles. No,
Right.
I can't do that right now, to be honest. And, but it's the doing what you can to try to stabilize the joint as much as possible. And I
Right,
think
and
that can
I
make a
think
massive difference.
well, and like you said, like, being able to find, like, a physical therapist or even working with somebody who understands kinda how to tailor it to somebody that might have these joint mobility as well as these additional signs that go along with hypermobility, EDS. So it's not
Yes,
just any exercise, it's the right type
it's
and
the
the right
right
frequency.
thing. And that's going to change per person. I mean,
Right.
and it can even change per day. Like some of the exercises that I do personally, there are some days I'll get up, like I do dips, and there's some days I'll get up there and I can do them no issues. Other days I get up there and I go down. I'm like, nope, my shoulder's not going to do this today. Like just,
Mhm.
I can feel it. So I
Right.
don't do it. I pick a different thing, a different way to work out the same muscle groups, but
Mm.
just not that way because of the basically mechanical stress I put on the joint. It just,
Mhm.
the joint's not going to have it that day. So you do something else. And figuring out all that stuff on your own can be difficult, especially for patients with hypermobility. Sometimes can have very low energy to begin with because
Yeah.
fatigue's a big part of it too.
Yeah, and that's, one of the questions I was gonna ask is how do you as somebody who has hypermobile EDS, like, how do you explain this to your family or say you're a kid, you have this and you have a teacher, you have your PE coach, I'm thinking I have a 14-year-old son, I'm thinking, I'm like, how would he explain this like his baseball coach or even employers, right? So, because you have potentially this fatigue, you might have dizziness, like you said. So, how do you explain this to other folks? Because I think it's one of those ones too where for people who don't understand, they could misattribute it to other things or maybe not be so kind or understanding in what's going on. So how do you explain it to folks in a way that maybe they can understand?
Yeah. And so one of the ways that I have explained it to both patients and just other people in the past, which I will preface this with, this isn't the most accurate thing, especially given what we kind of think today, but
Mhm.
I think the idea behind it still works. So, because while we don't No, there's a connective tissue component to it. I used to just tell people, collagen. That's what a lot of the other types of EDS are related to. So it's just easy to use that. So I basically said, like collagen isn't made properly to the extent where it doesn't kind of hold everything together like it's supposed to. So like, let's say if you're normal and you can interlock your fingers like this, but if you're trying to pull them apart, you can, it's hard to do because your fingers are kind of pressing on the back of your hand. Whereas, let's say if you have hypermobile EDS, you're trying to do it from here and just more squeezing your fingers together, and it becomes, you can slide it
So you're
apart
not as
easy.
like, yeah, it's not as clutched tightly with your fingers overlapping. You're kind of starting from a point where they're already kind of slightly pulled apart to begin with.
Yeah, and it means it's going to be weaker and looser and more unsteady,
Mhm.
just naturally. And then, so it means you have to be careful. Like I have learned over the years, don't move certain ways. Like if I sit in some positions, the next thing I know, I'll get intense hip pain because it feels like my hip's about to dislocate. And just kind of doing part of it's just a learning experience, unfortunately, where every patient's going to be different. But it's figuring out where your issues are and what you can do to help support it. And because it's just not there normally.
Right, and I think it's then being able to communicate that to other folks about, whether it's sitting in an office and you need certain, chair or, like,
Yeah,
OSHA requirements or whatever, but also, like, if you have certain movements, like you said, that you have to avoid or not do as much. And do you find that people are fairly receptive when you kind of explain, what's going on, and that they're like, you know, try to figure it out or be more understanding potentially?
potentially. I mean, in my experience, yeah, most people have been very understanding. For me, like when I've been the person explaining it to people who don't have health issues and just being like, hey, listen, here are some things to keep an eye out on. Like, especially before I knew how much water I had to drink and I was passing out a lot more,
Yeah.
that always came up. And I used to tell people, like, just ignore it. I'll wake up in a second, just
Yeah.
like don't call an ambulance unless I bust my head open or something.
Mhm.
But even when I interviewed for residency, I remember asking, the program directors, I was like, I have a big requirement, not that big, but it was, I'm wearing tennis shoes. Like, if you expect me to come in dress shoes, we're just not a good fit for each other. And like, no harm, no, not a big deal. But I was like, I'm wearing tennis shoes because it's just more comfortable for me. And especially for a condition like this, and there's like this concept called the kinetic chain in your legs where like if you hurt your ankle, well, your knee could hurt even though your ankle's messed up, or your hip could hurt, and it's kind of all this upstream effect. And I was like, I'm just not messing with it. I'm wearing tennis shoes,
Mhm. Yeah.
and
You're like, I'm
thankfully
not even gonna
everyone was
take
like
that
super
chance.
cool with it. Yeah.
That's good. That's good.
So
One thing when you were talking about and describing like the collagen, and I know this has come up with me in conversations with folks not from science gen background, the collagen that we eat or consume or that is sold to us as a dietary supplement, does that have any bearing into helping with somebody who has either EDS or one of the I guess for sure known collagen connective tissue disorders?
not a single bit.
Okay.
Collagen is a really large molecule. Actually, it's massive. You can't absorb it.
Mhm.
So your body breaks it down into the amino acids that it makes up or that makes it up, and then it absorbs it that way. But then you have to take the building blocks of collagen and rebuild it, which your body doesn't do necessarily correctly. So you're just at best, you're giving your body building blocks to make a protein that is not structurally correct,
Mm.
which
Okay.
then doesn't make a difference.
Right. Right. That's I think that's helpful because I think that that's a common question too that people will ask is like additional supplements, right?
Hmm.
For folks that um, have a diagnosis of hypermobility EDS, are there any support groups or resources that you would recommend for them?
There's definitely a lot of support groups, especially online, even among like Facebook. Like I'm from Georgia originally, And there is a Georgia specific, EDS Facebook group, for example. Excuse me. And, I'm sure there's plenty others that are like that as well, that you can get plugged into. That's actually how I first became kind of interested in patients with EDS. Is my dad truthfully kind of nagged me for years to join one of those groups so I could see what other
Hmm.
people have to experience. And when I did that, I was like, oh, wait, this actually can't be bad, because I didn't consider myself to be bad. I was in pain, and I was kind of flexible is how I viewed myself. And then I kind of saw what it was like, and I said, okay, wait a second. This would be a good place to work, because there's not really a medical home for those patients. Then there's also something, the Ehlers-Danlos Society online, which also has resources as well, for various different aspects of, treatment and management for patients with it, as well as like a list of providers and, things like that, as far as like who sees patients with EDS in whichever area you're in, that you can go and try to get an appointment with, and,
Hmm.
as well as just other opportunities related to the condition.
Well, and so you'd mentioned, getting involved in some of these groups and kind of inspiring you to work in this space. Before we wrap up, is there anything you want to tell us just in general about kind of the work that you've been doing, or where you hope to see some of the research or clinical care for folks with hypermobility EDS go?
So right now at MUSC, so since I'm new here, we're still building everything. And we also have something that's opening up, I believe, in the next week or so, kind of right around this time. There's a EDS clinic that is opening. Dr. Ann Maitland is the director for that clinic. And,
Hmm.
Russell Norris, who's the head of the Norris lab here at MUSC, they were the ones that did that paper about KLK15, and they have more papers out. Some stuff hopefully actually getting published in the next couple of weeks here related to hypermobile EDS as well. So they're
Hmm.
doing a ton of work in that group, and I'm very excited to be here and be, a part of it too. I'm also gonna be having kind of like a separate clinic, just because actually it's a very prevalent disorder, especially when you look at genetics. It might very well
Hmm.
be the most common genetic disorder, because some, estimates have ranged. Some have estimated it, I guess, frequent as 1 in 300 or 1 in 500 or so, will have the disorder. And
Hmm.
so, like, one clinic will never be enough. So that's where we're currently working for me to also have a dedicated clinic to see patients with hypermobile EDS, both adults and kids.
Okay.
Most genetics clinics in the country will see kids for hypermobile EDS evaluations. So it's just kind of the adult side that can be difficult.
I mean, that's exciting that you have found your way into this, as your career, and that you're now in this position to further the research to further access to clinical care as well.
Yep.
But like you said, you recently started, so it's cool, and I'm excited to see like what happens over the next few years in this space.
Yeah, I am too. And I also want to say, because I think a big person that drove a lot of this getting done here is Dr. Courtney Gensimer, who
Hmm.
she was a PhD student in Russell Norris's lab. And she kind of pushed a lot of that research. And now she's here as faculty as well. So she's done a ton of work with it. So, just everyone involved. I'm really excited, to be here and to be working with everyone. And it's amazing how much I feel like I've learned from them, even just in my short time here, so
Yeah.
it's really exciting.
Very cool. Well, we'll put some more information too about the lab and some of the resources you mentioned in the show notes as well. So if people want to take a deeper dive or learn some more that they can. But I just appreciate you taking the time and being on with us today, Taylor.
Absolutely. I've enjoyed it. I'm happy to be here and, happy to talk about this.
For more information about this episode, visit allaccessdna.podbean.com, where you can also stream all the episodes of the show. Any inquiries on the podcast can be sent to allaccessdna@gmail.com. Please rate and review the podcast on Apple, Spotify, YouTube, or wherever you listen. This helps other people like you discover the show. Note that this podcast is for entertainment and education and is not intended to be a substitute for professional medical advice. Please consult your physician with any questions you may have regarding your health. All Access DNA is an independent podcast hosted and produced by me, Kate Wilson. Designs by NKJ created the logo. Thanks for listening and join us next time.